They wanted me to talk a little bit about sort of CVS Health, and in particular about sort of the decision to get rid of the tobacco products. And the decision about getting rid of the tobacco products has raised some interest in business communities and a little bit amongst academics and things like that, simply because we're about this year we'll be about $132 billion in revenues, but the tobacco itself was about $2 billion in revenues, and for our front store it was the single biggest item in the front stores. And it also had a lot to do with, basic things that go on there. Like we had a number of front stores, a couple here in Pennsylvania, in Philadelphia, that would basically open at 7 a.m. just to catch the smokers because they were buying tobacco on their way to work in the morning. So it was a big deal. And I would say when I got to CVS nearly 6 years ago, there was absolutely no interest. In fact, I would say the thought hadn't sort of crossed their mind that they shouldn't be selling tobacco products in pharmacies. Now, I wasn't really such an innovator in the regard that I thought that was not a good idea for us, but because the American Pharmacists Association, for about 12 years previous to that, had basically had a published statement that it was unethical to sell tobacco products in pharmacy. So it was clearly recognized by the sort of pharmacy professionals that it didn't make sense to be selling the sort of number one poor public health product in pharmacies. And the AMA had been on board for about 8 to 10 years. And it was an issue that at least the pharmacists were sort of aware of. And although we don't have a lot of pharmacists in senior management, my CEO is a pharmacist. The guy who runs the pharmacy benefit management company, Caremark, is a pharmacist, and long-term pharmacists, 30 or 40-year pharmacists at CVS. So they were aware of the issue from sort of a professional point of view. But the question sort of became, and I'm not very good, having sort of been raised in management in a teaching hospital, I never kind of learned the sort of subtleties of management. It was more, like who won the argument at the end of the day type of deal, at least up in Boston. I'm sure things are much different here in Pennsylvania. But nonetheless, it required some reflection to understand sort of how we might be able to sort of go about that. And I think that the critical thing was really that we began to put in place sort of strategies that were much more oriented towards the healthcare system. If you think about the sort of pharmacy industry, and basically just to tell you a little bit about our company. So I said, we're about $130 billion in revenue, but we'll go to probably 160 or 170 over the course, if everything goes well, over the course of the next 2 to 3 years, just because of the growth in use of and introduction of specialty medications, which are very expensive and increase our revenue. But that makes us, that'll make us like the 6th or 8th largest company in the country from a revenues point of view. So it's a big company, but the aspects of it are basically the retail pharmacy, which you would recognize from CVS because we have a good market penetration here. In that particular segment of the company, about 30%, 20% of the revenues, 30 going down to 20 are from the front store, what we consider to be the sort of front store. And the rest is from the pharmacy. And that's different. Years ago, it would be more like a sort of 50-50 deal. And that's also different than what most people sort of think about with regard to the retail pharmacies. A lot of our clients on the PBM side, and I'll talk about the PBM in a minute, think that the reason why we have a pharmacy is because we want people to shop in the front store. And basically, they think people are going to come in to get their medications and they buy a garden hose. It's actually not that case at all. In fact, we're pretty well divided in terms of front store shoppers and people who are sort of using the pharmacy. So the front store doesn't sort of play as big a role, and it's played less and less of a role kind of over time. And then our company, just before I got there, and the thing that sort of interested me in going there, I was at Aetna and worried that my wife was beginning to set down roots in Hartford, and so I figured we had to get out of there. We're in Woonsocket, Rhode Island, at CVS, but that's close enough to live in Boston, so that was good. But also, I was fascinated by the move they made to buy the PBM. So the pharmacy benefit managers were basically the sort of enemies to the retail pharmacies, and the retail pharmacies hated the pharmacy benefit managers because the pharmacy benefit managers had managed over a sort of 20-year period of time to insert themselves in the middle of things, and basically were slowly but surely sort of reducing the amount that the retail pharmacies were being paid. So it would be like hospitals and insurance companies on the pharmacy side. So the two coming together, I thought was a really sort of fascinating move because, at least from my point of view, it was similar to what you might be thinking about with an ACO or a hospital that's basically getting insurance data and taking risk. We don't take a lot of risk, but the PBM group is very facile with data, and also has a huge B2B workforce. So it gave you kind of a B2C and a B2B approach in healthcare, and it was nicely concentrated on the pharmacy side. And as an internist, I like the pharmacy stuff. So the marriage of the two seemed to me to be very interesting. And then the other aspect they had that was kind of understated when I got there was the retail clinics. They had just bought that, but they were thinking about getting rid of it because they were losing a ton of money on the retail clinics. But that also seemed to me to be something interesting because, at least with the front stores, what you've got is basically convenience. We got 7,800 of those, and they're designed to be convenient and for people to get in and out of easily. And the direction healthcare is going, it seemed to me, more individual policies, the exchanges, more consumerism, more high deductible plans, all sort of oriented things towards a consumer approach. So, being able to sort of make consumer care available in a really convenient setting like that seemed to me to be fairly disruptive. And especially when you had this front store, you got in between sort of 6,000 and 20,000 sort of square feet of space in which you could do other things other than sort of sell cigarettes and candy. Seemed to make good sense. So all those things, all the aspects of it, made it for what I consider to be a very strategic organization, and one that could then be sort of brought into the healthcare system, as it were. So with the retail clinics, we've basically sort of sat those back up, got them to break even, and now we've been adding. So we add like 3 to 4 of those a week, and we've been doing that for couple years, and we'll continue to do that for the next 2 or 3 years. So we can get up to about 1,500 or 2,000 of them, and then we'll have good penetration for employers, basically national employers across the country. And it gives us a sort of national opportunity to sort of provide care, which is a good thing to have. So with all those assets, we began to sort of make the case we need to get closer to healthcare. Because the other thing, when you look at it, sort of if you ask like a developer, I'm sure there are people who do this here at Wharton, but if you ask a developer of a shopping center, who are the customers? They always have an argument as to it's the people who come and park in the parking lot or the people who own the stores and are renting the space. Really in healthcare, you kind of have some of the same questions. You might have a customer, if you're operating a hospital, are your customers the patients or are your customers the insurance companies? I think in the hospitals that's fairly clear. But the point of the matter is that when we're thinking about it, we got to be thinking about who our customers are. Are our customers the patients who are coming in and getting their prescriptions, or are our customers the doctors? Because every bit of business that we get, and we make all of our money, basically most of our money on these prescriptions, is coming from a doctor. And they had never really sort of thought about the fact that their key consumer of sorts was the doctor. But then figure if you could get closer to the doctor, then you could really drive more business. And the idea being, if you're a doc, and for years I was, okay, I'm writing your prescription, or do you want me to call in your prescription? Okay, what pharmacy do you use? Didn't make any difference to me what pharmacy it was. It was whatever pharmacy they used. I wasn't trying to drive them to one pharmacy or another. But it seemed to me that, from a strategic point of view, if you could develop better relationships with hospitals and doctors, then you could eventually get to where the doc would say, hey, we're working with CVS and we think they do a better job. Maybe you should go to CVS. And so that kind of thing, if you can get that kind of thing in our business, so-called share shift, it's like magic. It's tremendously sort of profitable for us to get that sort of share shift. Now, people were skeptical that you could actually get the doctors on board with doing that. But then the other thing that was occurring sort of as I went to CVS was healthcare reform. Healthcare reform is a lot of things, but at the guts of it are that it's a move towards making the physicians and hospitals do more population management, right? If you look at all the programs that CMS has got out there with regard to sort of healthcare reform, obviously it's an access approach, but if there's any changes in the payment system, it's towards population management. So if you look either at all the things that CMS is doing, or you go to the analyst day for any of the large insurers, all they talk about is how much of their business is going to be based on some sort of set of measures of total outcome. So no longer are they interested in, and I think by and large, you shouldn't be interested in fee-for-service medicine because that's basically going to sort of drive inflation and keep the same very expensive healthcare system in place that you have today. I'm not going to sit here and say that the ACOs have sort of got that all figured out. And I'm certainly not going to say that everybody's moving off of fee-for-service. You go to a lot of places in the United States, and the good thing about my job is you get to see the sort of entire healthcare system. You see a lot of places that are in fee-for-service are going to be there for a long time. But the impetus is in the direction of population management. That then goes back to another thing that we were doing. So before I got there, but not much before I got there, they had sort of figured out that, hey, adherence is important. So adherence to medications, not something that you learn a lot about in medical school, but it makes good sense to the average person or medical student or doctor. Like a patient comes out of the hospital after having a heart attack. If they take these 5 medications, they're going to reduce their risk of heart attack by about 60 or 80% and their chances of suffering congestive heart failure by about 50%. So if you take the medications, you have fewer poor outcomes on down the line, okay? So 2 insights about that. So first of all, we got there because actually if somebody's not adherent and they don't pick up their medication, we don't get our prescription fee. So if we encourage adherence, we make more money because there's more prescriptions. So our team could get that pretty easily. Adherence is an important thing from the point of view of sort of our business interests. But the other point around sort of population management was it was fairly clear, and we've done research. We do a lot of research, and some we do with Kevin and the team at the Leonard Davis Institute. Some we do with a group that we have up at Harvard. But and also we have an internal research group. But we've done a lot of research, and others have done a lot of research that basically was able to sort of quantify how much a return there was on use of medications. So the average patient is about 50% likely to be taking their chronic disease medications at 6 months after they are prescribed. So you've got a huge target there, and one that would be very attractive to us because if we can get that, then basically we increase our revenue by 100% if we can get those people to be adherent. But also you've got a potential to sort of really reduce healthcare costs if you can get people to sort of take their medications, right? So we did all these modelings, and we finally got CBO convinced. But suffice it to say, in the population management section, now if I go and talk to a group of docs or hospitals that are thinking about population management, the way they're thinking about it is from the point of view, okay, 100,000 Medicare life. If I talk to them about, okay, you're going to take on risk for 100,000 people in a Medicare Advantage program, their spend, give or take, is going to be $1.1 billion in the coming year. The modeling that we've done over time, and I think it's pretty widely accepted, would suggest that if you could get those 100,000 people to take all their medications and fill all the gaps in care that they have associated with those medications. So one thing is that patients don't take their medications. That's the adherence problem. The other problem is that docs are likely to follow evidence-based rules only about 50% of the time, leaving half the patients with some sort of gap in care. So if you can get all those gaps filled, make sure everybody's adherent, then you can reduce the total costs associated with that Medicare Advantage program. Now, the average doc group or ACO that's looking at Medicare Advantage, what they really don't want to do, they don't want to lose a lot of money. If they can eke out a 1 or 2 or 3% margin, that might look good compared to how they're going to do long-term on Medicare fee-for-service. So how much money can they save? Our model would suggest that they can save, if they got everybody to take all their medications and filled all the gaps in care, they could save $270 million. Of that $1.1 billion. So those numbers are widely accepted now. If CBO has modeled those numbers, you're never going to get everybody to take all their medications. Everybody's not going to be adherent. But if you can get sort of 50% of that or 30% or 20% of that, that's really good. So the idea was we're going to develop these programs that we've been developing internally for the pharmacy on adherence and filling gaps in care. And we're going to start to work with the doctors and hospitals on those things. But you can see the point here is that the strategic plan was to sort of creep into the healthcare system. The pharmacies have been sort of in a way outside the healthcare system. Some integrated systems operate their own pharmacies, but by and large, they're completely separate from the rest of the healthcare system. And what we were saying is, a good plan here is to be working directly with the doctors and the hospitals and treat ourselves as part of the overall healthcare system. I think, our team could get that and could see the value associated with that. And we began to put more and different kinds of adherence programs in place and emphasize the health impact of that. We're obviously not going to emphasize the fact that we make money on every prescription, but we're going to emphasize that this is improving health. We're in a nice sweet spot in the healthcare system where our business interests are directly aligned with higher quality and lower cost care. We make all of our money on generic prescriptions for chronic disease. So, sort of having said all that, what we were doing was basically sort of creeping towards the healthcare system. And then as we began to sort of put the hook in there, that's when we had to have the discussion about tobacco. Because the point would be that we made both to the board and to the senior management team would be that, you can't be selling tobacco products and be a healthcare company. So people began to get interested in sort of changing the name of the company and doing more advertising around these issues. But, you really had to say that the tobacco was kind of in the middle of it. Now, that doesn't mean that everybody sees it that way. Walgreens, their advertising campaign is at the corner of happy and healthy. They don't seem to have a problem with regard to sort of selling cigarettes. But I figured that if we're going to be out talking to the doctors and hospitals, this was going to be an issue that was going to be relatively important. And moreover, over time, I think that, at least from the point of view of our CEO, there was kind of an integrity, not with a capital I, but just with a small I, that if you're really going to be emphasizing health, you can't be selling unhealthy products. Now, you might say to me, well, you got a ton of unhealthy products. You're just out in Indiana in a store. No cigarettes in it anymore, but, walk down one aisle, it's all liquor. We're the 4th or 5th largest liquor distributor in the country. We don't sell liquor in the Northeast because they won't allow it, but we sell a lot of liquor out in the square states. Then the next aisle was candy aisle, and then the next aisle was the Halloween candy aisle. So there's a lot of other, but in many ways, all that stuff is things that if you use in moderation is not really going to harm you. Whereas there's no way to sort of make that argument around cigarettes. The other thing that we were able to sort of point out over time that I think was a relatively sort of winning argument is that the cigarettes themselves, there's about $2 billion in revenue, but only about $180 million in margin, or EBIT as we would refer to it. So they weren't highly profitable, really. But what was interesting was that you did make a reasonable amount of money just from the renting of the display area. And if you go into like Walgreens today, or you'd been into one of our places, sort of where you check out, that would be a sort of large selection of cigarettes right there. And the cigarette manufacturers would pay dearly in many cases for us to have all that cigarette display right there. Now we've got a smoking cessation display there. But the reason why they paid for it was if you start to get into the kind of dynamics of smoking and smoking cessation, things like that, 70% of the people who are smokers say they're trying to quit. About 50% are actively, sort of motivated to quit. And of that group, there's a large number that are basically going to be buying cigarettes on basically kind of a spur-of-the-moment decision. It's relatively sort of spontaneous. And so, just like as we put candy out at certain kinds of candy out at the checkout line, if you go to the checkout line and you're in that dynamic relationship, you're going to buy cigarettes. And the interesting thing was that the tobacco companies knew that, and that's why they paid for that. And the tobacco companies also very worried about lack of sales in retail pharmacy because it's one place where a large demographic section is constantly shopping and they want exposure there. So another thing that we learned over time is that about 13 to 14%, nearly triple of what the previous estimates were, of cigarettes are sold at retail pharmacies. So making these arguments that we were like basically kind of shilling for the tobacco companies was helpful, especially with certain members of the board who again were concerned about at least the small I integrity issue. And so all those things enable us to kind of gang up, as it were, to begin to move in the direction of getting rid of the cigarettes. But our board was very clear because we got to talking about sort of how we're headed into healthcare and what the name of the company should be. And they said you can't name the company if you're selling cigarettes. Now they weren't. I wouldn't say that was sort of unanimous amongst the board members, but critical board members really felt like we had to sort of make this move. And that's really what gave us, when you work at a public company, that's really what sort of gave us the impetus to go ahead and make the decision. Now, the upshot of it all has been good. There were over time, 5 years ago when I was bringing this up, it was going to be financial disaster. We're not going to talk about it again because we can't afford the loss of sales. And then if that didn't work, then it would be, people are going to go elsewhere to buy cigarettes anyway, so it's not going to have any public health value. Well, that was the sort of last thing we had to address in order to get the decision made. And interestingly, there was data. This is a good thing about sort of having a bit of a research background and being in a big public company like this. I found out sort of serendipitously talking to the retail people that there's this data out there that they use all the time that comes from IRI, Nielsen. And basically, you all would probably know about it, so those of you who've taken a merchandising class. But basically, there's about nearly 250,000 people out there who, whenever they go out and buy something, they bring it home and they got a barcoder at home and they put it through the barcoder, and the barcoder identifies what the product is and where they bought it. And then that information all goes to IRI, and then IRI sells that back to us and all the rest of the retailers. So that we can know sort of where people are shopping and what's happening to the shopping for certain categories that we have, and where how other people are doing. So it's a good kind of thing. It's kind of like IMS data on the pharmacy side. But the interesting thing about that was it was the first time that there was sort of a glimmer that we could actually sort of study what happened when they put bans in place in Boston and San Francisco. About 2 years apart, they put the bans in place, but they banned the sale of cigarettes and tobacco products at retail pharmacies. And so we went to IRI and bought the data from them for San Francisco and Boston, and for Seattle and Phoenix, I think, or Seattle and maybe Philadelphia. And what we looked at was what happened to tobacco purchase. And what we found was that there was about a 13% decrease. Once we adjusted it, maybe went down to sort of 6 to 7%, but it was still statistically significant decrease overall in purchase of tobacco products. So clearly this notion of a sort of removing a visible place where you could buy tobacco products was leading people to sort of stop smoking. And then we had sort of the public health argument about, answering the argument, well, if they don't buy cigarettes from us, they're just going to go elsewhere. And so all those things kind of put together enable us to get to the right decision. But the good thing about it from our point of view was then we were ready on the public relations side to go with the new name of the company and begin to change our image. So the whole idea behind sort of getting close to the healthcare system, people wouldn't be thinking of sort of retail pharmacies as colleagues who they sort of might be working with. But if you begin to do things that look like they're really healthcare oriented, and you offer programs in which you can basically work together with other parts of the healthcare system, then you begin to sort of open up the door. And so what we ended up with was a decision that looked like it was very principled, but as with most decisions in corporate America, it was very much kind of in keeping overall with what we thought were the best things to do on behalf of the shareholders. And the result is the stock price is up about 25 to 30% since we made the announcement earlier in the year, and it's really given us sort of a leg up on our competitors in a bunch of different areas, but in particular in terms of trying to get close to the integrated systems and work more closely with doctors and hospitals and the like. The other thing that I would say that was important about it is that, and this is something that's not to be overlooked, and I think my boss does a good job of thinking through these issues, is the effect it's had overall on the workforce. There's really something to be said for sort of doing what looks to be the right thing to make people feel much better about their work. And so if we look at sort of our overall engagement scores for our employees, they've gone up relatively dramatically over the course of the last 4 months. Mostly we think because people feel like this is a good place to work, this is a place where we can be proud of, this is a place that's sort of doing the right sorts of things. So that's basically kind of explains the story behind how a corporation like us, which is oriented like any other corporation towards shareholder value, making sure that the stock price is continuing to go up, can get to a decision to forego a reasonable amount of revenue in a way that ends up being better overall for the company.